Hey everybody, and welcome to GI Psychiatry Q&A. I'm really excited to see people joining and partaking, and I really appreciate all the questions that actually were sent in advance of this as well. I've gotten a chance to look over some of those and definitely going to try to hit the highlights of all those questions as possible. But feel free to add in extra comments here or questions that come up for you guys as we're chatting about these things. I'd love to see those questions. And if I can't get them tonight, if I can't get you a good answer for them tonight, then we will definitely host more of these. I'm planning on having them at least monthly. And hopefully we'll have some guests joining us along the way as well. I wanted to kick it off, I guess, with just talking a little bit about gastrointestinal psychiatry. I have a post that had a lot of comments on it, and a lot of people saw it a few weeks ago. And I think it's helpful just to revisit sort of what is GI psychiatry, what is not GI psychiatry. So I'll tell you a little bit about my background and how did I get into this in the first place. I went to medical school for 4 years, did the usual course of that, went into residency for psychiatry, and was really missing and talking about all the different medical illnesses, all the different medical knowledge that was gathered for the 4 years of medical school. And I found this subspecialty called consultation liaison psychiatry, and it's about the interface of medicine and psychiatry and how those overlap, right? Sometimes psychiatric conditions can worsen a medical condition. Sometimes medical conditions can actually contribute to psychiatric issues. If you're going through something, chronic pain, having issues with your gastrointestinal system, which we're going to be talking about tonight, that's a very difficult thing to go through, and to not feel at times isolated or have your mood dip doesn't automatically mean that you have depression or anxiety or anything like that, but it definitely takes a toll on all of us. So that interface is where I found a home in psychiatry, and I've gotten even more, niched into it with gastrointestinal psychiatry for a number of reasons. One being that there is such a high need for this, and there's not a lot of doctors that do this. I'm probably one of about 4 in the country that specializes in gastrointestinal psychiatry, and a lot of the other few are mostly in research, in academic centers, and it's harder to get access to them. So I think it's really important that there's a voice out there talking about how does gastrointestinal psychiatry work, and maybe we can get more psychiatrists to think about this kind of work as well and get some knowledge out there. The other thing, and some of the questions that came in were about medications and how they cause GI side effects, right? So if I'm prescribing for somebody and let's say they have a gastrointestinal issue and I'm prescribing medications for them, maybe it's actually causing another gastrointestinal side effect. It's important for us to think about, in psychiatry for sure, but in medicine in general, what's the risk-benefit analysis to taking a particular medication? How do we think about, utilizing side effects of medications? I'll talk a little bit about that as well. And picking the best medication to have the least number of side effects and have the best outcomes for patients is really important. So that's a really broad overview, and we can definitely talk a little more in depth about gastrointestinal psychiatry as we go along. But I thought it would be great to sort of kick it off with thinking about some of the things that go on or some of the questions that I've gotten so far in my Instagram live and requests. And the first one is thinking about, actually, this is a great question. Somebody asked, do I actually see patients taking anxiety medications notice an improvement in irritable bowel syndrome symptoms? And right, that's my bread and butter. That's gastrointestinal psychiatry. Again, as always in my videos, what I like to make sure I'm mentioning is that IBS, which is a functional disorder, and function refers to the organ not functioning in the way we would expect it to. So it doesn't automatically equal that, it doesn't equal at all that it's in our heads or that we're making up these symptoms. It's that the organ is not doing what the job that we would expect it to be doing. And there's lots of different reasons for IBS to come about. And it's important to, have that conversation with your gastroenterologist, have that workup to make sure there's nothing being missed. It's a hard thing to do, for sure. Gastroenterology is, based in blood tests, scopes, and motility testing for the most part with irritable bowel syndrome. And sometimes those results are not very satisfying, and it's very upsetting, and it's very frustrating for patients to not have an answer for what to do next. So the starting place, actually my post today, the slides today, was really noting that it's important to get these workups and to advocate for yourself as a patient. Patients are coming to me after they've had that workup. They're working on how to tackle some of these symptoms. Maybe they're already on some other medications, but maybe there's also a component of anxiety around the unknown of this diagnosis. Maybe there's a component of their medications that are causing side effects for them, or they can't tolerate the IBS medications. And also at times there is anxiety that just worsens the IBS, right? It's not causing IBS, but it can definitely make the symptoms feel more heightened. If our brain is really focused on those symptoms, it can make it feel a lot worse and feel a lot less tolerable, and make it really scary to feel like you can go out in the world, and even though you're dealing with these IBS symptoms, figuring out how to go out in the world and live your life. And so that's where GI psychiatry can come in. Once you are on the path of working on irritable bowel syndrome, you might also, be trying to think about how do we work on the autonomic nervous system, or that fight or flight response that's happening when anxiety kicks in, when you're trying to figure out how to tolerate all these unknowns with either medical workup or just the world around you, what your gut is going to do in the context of the world around you. So, if you fall into a category like that, if somebody falls into that category of having IBS and it's getting worse from anxiety, or their anxiety is like inhibiting them in some other way, those can be parallel pathways. They can also intersect. It's very dependent on the person, but in those cases, yes, for sure, I see patients benefiting from treating their anxiety. That doesn't always equal medications, but I think medications can be a very helpful tool for patients if they are struggling with the anxiety, or they're having a hard time engaging in behavioral therapy, right? So trying to go out into the world and not be focused on the food that they're eating, or trying to not be looking around to see where is the next bathroom for them. If they're trying to work on that, but it's so anxiety provoking that it's really tough to do that, then medications can really be a big part of the process here. It's a tool. It's one of the tools that we can possibly use. And I think about that too, what I was saying before about having side effects to certain medications. I know somebody wrote in saying that, they're like, every medication causes side effects. Every medication can potentially be a problem. That can be true. I think that's why it's so tough to have a lot of people out there prescribing psychiatric medications. It's a double-edged sword. So on the one hand, it's very, very good to have access to more people prescribing medications for anxiety, for depression. Primary care doctors are really doing a heavy lifting with that, trying to get people on medications to help them, especially if they hear depression symptoms or anxiety symptoms. The problem is that not only do they not have the bandwidth, the time, they are seeing patients so quickly because they have to. That's part of a flaw in the system there, but it's an issue that they come up against. They try to give you a medication, And it might have a side effect that not because they interacted with any other medication, but you personally weren't able to tolerate that medication because you have IBS. Our gut is very sensitive to new drugs. It's really hard to have an intestinal issue and to just sort of throw a normal dose, right, of a medication at your intestinal tract and ask it to digest it as we would expect. So that can be really complicated for patients because they get put on a dose of a medication that they're hopeful will help them, and it wouldn't be the dose that I would start the patient on. It might be too high of a dose. It might be too quick of an increase of the dose of the medication. And it also just might be a medication that is good in theory for anxiety, but depending on the symptoms, and let's go back to IBS for a second. If you have IBS with mostly constipation, I wouldn't try to pick a drug that has a higher risk of constipation in patients. And everybody's different, right? We can't totally predict what side effects someone's going to have. But if you are more likely to have constipation as a person, there are certain drugs that would be less likely for me to want you to be on because they could have a heightened response of that. It could make it worse. And then on the flip of that, if there are medications, or if there's a patient who has IBS with urgency and diarrhea, I might pick some of those more constipating medications because it will be helpful for their anxiety, and it also has a little bit of that benefit, that extra piece to it where it's helping with some of the GI symptoms. That's not actually just the only way that psychiatric medications help with IBS and with functional disorders in the gut or gut-brain axis disorders. There are a lot of patients that, are taking medications, and it's for more of a neuromodulating effect. The neuromodulating effect is that, we're working on the serotonin receptors in the gut, just like we're working on those serotonin receptors in the brain for anxiety or depression. We have actually the highest number of serotonin receptors in our intestinal tract compared to anywhere else in our whole body. So it's an interesting, it's interesting to think about that. How are we impacting the brain? How are we impacting the gut, which are very tightly connected and have been tightly connected since, you were born. They come from the same group of neurons that were developing over time. One becomes the central nervous system, the brain and the spinal cord. One becomes the intestinal tract. So our drugs are absolutely working on both of those sets of receptors, and we can see neuromodulation in patients using these medications both for anxiety, depression, but also for functional disorders and for gut-brain axis disorders. That actually it's maybe a helpful segue a little bit into a patient was asking about OCD in gut-brain axis disorders and how does that play a role, right? And there is research actually thinking about how does our brain focus on parts of our body or over-focus on parts of our body. We see these in obsessive compulsive disorder, which is, it has a specific definition, and I won't go to that definition today, but if we have a truly diagnosed person with obsessive compulsive disorder and those thinking patterns like ruminations, catastrophizing, hypervigilance even is coming about, that can definitely make gut symptoms more intense because our nervous system is more aware of that. If we're constantly scanning our body and saying, is that pain? Is something getting worse with this? What does it mean? The brain is going to potentially turn up the volume on the gut sensations because we're just more aware of them. So this is actually classified as something called hypervisceral sensitivity, and I work with lots of patients that are struggling with that. It doesn't mean that there's damage in the gut in the way that maybe if you have inflammatory bowel disease, right? We think about ulcerative colitis, we think about Crohn's disease, where there are ulcerations in the gut lining. You could look at it in a scope and say there is physical damage to the gut lining in that case. Patients will, that's like different than having a gut-brain axis disorder and different than having hypervigilance, because our body is not actually damaged in gut-brain axis disorders. Again, those both could be true. You could have inflammatory bowel disease and have a disorder of the gut-brain axis. They are parallel. They can be parallel pathways. But if we just think about it purely in this hypervisceral sensitivity, that is that the gut is misinterpreting a sensation or a signal. And if we can turn the volume down a little bit on that, utilizing both psychotherapy and medications, that can just ease the intensity of how hard it really is to deal with gut disorders and gut-brain axis disorders. How does this sort of parallel with obsessive compulsive disorder? You can have intrusive thoughts about symptoms, about gut symptoms, about gut-brain axis disorders. And certainly I would say that relates to the trauma of trying to figure out what is your diagnosis and what's happening for you. And so ruminations and checking, again, those really can amplify the hypervisceral sensitivity that can come up in sort of a metaphorical OCD of the intestinal tract. And they certainly make each other more amplified. So if you have obsessive compulsive disorder and you also have a functional GI disorder, it definitely can make things feel more intense. Just going to look through for a quick second to see if there's any questions that have come up so far to throw in here and to answer along. Cool. Somebody's noting that they took medication for OCD and IBS got a lot better. That's amazing, right? That's an awesome outcome. It's really great to have that. When somebody's asking about the GI umbrella, am I also including colitis? So when I talk about functional gastrointestinal disorders, I'm not including colitis in that. So inflammatory bowel disease is an autoimmune condition that has actually, we can, as I said, we can see that on pathology. We can see that on a colonoscopy. That's not that the organ is not functioning the way we would expect it to. That's that our nervous system, our immune system is attacking parts of our body that we don't want it to, right? It's a misinterpretation of where to attack the body or where to attack a pathogen. And so I'm not including those disorders, but IBS is very common to see on top of inflammatory bowel disease. So having inflammatory bowel disease can have you have a diagnosis, and it seems, I think, initially more straightforward. And I say that with a huge caveat that there's a lot of medications out there. A lot of people can, tell you, okay, this is the pathology of Crohn's or colitis. But at the same time, you can be in remission and have still a lot of symptoms that are going on in your gut, which can be a result of irritable bowel syndrome because the gut has been damaged in inflammatory bowel disease, and then IBS is on top of that. So it's a big component of that. I want to go back to, I'm seeing some questions about being medication sensitive. And some people are noting, right, taking lower doses of the medications, which is, that's definitely a huge part of it. Picking the right medication for you. And again, that's a tricky process. They call it the art of psychopharmacology. And I think that is a nice term for it, which is that we have to try a number of medications to see sort of what can be most helpful for you. I try to, over the course of the last decade, working with patients, figuring out what medications, again, for using side effects to our benefit, which medication are we choosing, making sure that we understand the risk-benefit analysis, what are we going after here? If we can try to target the anxiety that might be contributing to some of your symptoms, there is, an important factor in that sometimes I have patients who, they do have a side effect from medications, but but they can tolerate that side effect because it is improving something else in their system, right? And so it's always a very personal conversation about taking medication. Nobody's the same. Everybody's body responds differently to these things. And so choosing a medication and trying to do your best at choosing the medication is a huge part of the battle. I use genetic testing with a lot of patients to see how are you actually metabolizing drugs, so both the pharmacokinetics, how the body is chewing up the medication, and the pharmacodynamics, so what we would expect to see as the end result of taking that medication. So I test patients for that to try to have a little bit more of a precision choosing of the precise choosing of the medication. And if it's possible, if something shows up there, if they really don't metabolize certain drugs well, then it's not that I would never give them that medication, but it wouldn't be my first choice probably for a medication for somebody. So I try to use as many tools as we possibly have to find out which medication somebody could tolerate. Choosing a smaller dose of that medication is very, very important. Choosing a slower increase of that medication is very important, which again goes back to being able to, have access to somebody who's prescribing, who can check in with you, who can think about these medications. And I know that's a high bar. It's not that accessible. It's not that there's as I said, I'm one of 4 gastrointestinal psychiatrists probably in the country. So it's not that easy to find that, but expressing that, advocating with your doctor who is prescribing the medications that you want to start at a lower dose, especially if you have GI symptoms, can be a really big help, and getting them to work with you on that. So that can be a big help. There was another question actually that I thought was very interesting that maybe people have tested or tried out here if they have abdominal pain or IBS symptoms that are not really responsive to other things, and that is the vagal nerve stimulators. There is a new one that I actually don't remember the name of off the top of my head coming out for IBS. It's not FDA approved yet, and it's a really interesting idea because the vagus nerve is one of the cranial nerves that comes out of our brain, and it is innervating or controlling essentially our heart, our lungs, and our intestinal tract. It's sending signals. It's a super highway of the messaging from our gut to our brain. And when we activate the vagus nerve, it's telling us to go into rest and digest mode. So going away from the fight or flight response, going into rest and digest mode to try to give your body a chance to, sleep, tackle some of the inflammation that maybe has been in your body throughout the day, or if you're flu season right now, if you're trying to get rid of a pathogen in your body, there's inflammation that's caused from that. And deep sleep is one of the best places where we can actually tackle that and reduce that. So if you're getting into rest and digest mode, your body's able to recover. If you're in an anxiety state, if you're in a fight or flight state all the time, there is a peptide actually that our body reduces. So if your body's under physical distress or psychological distress, there are peptides that our brain is releasing called corticotropin releasing hormone. And that basically tripwires and says time for our bodies to kick into inflammation mode. And that will release cortisol, and we all, we've heard cortisol a lot, and there's probably more to say about that than in Instagram Live, but it is a part of our system that tells our immune system to basically activate and start working and looking for a pathogen of some kind, and be protective for our bodies. And the interesting part about that is that it has a direct impact on the intestinal tract. So the cortisol itself has a direct impact, but the corticotropin releasing hormone also has a direct impact. So if we go back to thinking about our body is under psychological or physical stress, they're kind of equivalent to the brain. If you're under stress, you're under stress. corticotropin releasing hormone is released, and it is targeting the gut as well, the colon. It can actually make hypervisceral sensitivity happen, so you notice more sensations. It can also go either direction in motility. It can slow things down, or it can really speed things up. So that's why a lot of times people say, like, what? If I heard somebody was under stress, but, they couldn't go to the bathroom, or they could go to the bathroom, and I'm the opposite of that. It still could be the same process, which is, objectively very frustrating. But our bodies respond in all different ways to corticotropin releasing hormone and to cortisol when we're under duress. So again, that goes back to why do we choose medications? What's the point of even working in psychiatry and trying to work on your mental health? It's to help downregulate this so that your vagus nerve can feel like it's safe to go into fight or flight mode. So all the way back around, that loops me to the vagal nerve stimulators. And somebody asked me, do they work? There's research to show that there are some potential positives in the vagus nerve stimulator world. There is probably less research to think about than compared to biofeedback mechanisms, where you're really trying to control your autonomic nervous system, or tell, feedback to your vagus nerve that you're safe and you can rest. But the vagus nerve stimulators, there's a whole different host of kinds of them. And there's a lot of, potentially researched ones, and there's probably a lot of sham ones. And that means, like, maybe they're not actually doing something for our body. But it's basically trying to get our vagus nerve to release the rest and digest situation for us, and to get us into a different place. Some studies have shown some benefit in patients. It's probably more likely to be found in patients who have, like, different types of pathology. More constipation has been researched a little bit more. So IBS with constipation, it could help with having more complete bowel movements in the week, a little bit less abdominal pain, maybe less of a pulling sensation. And it helps to basically improve what we call vagal tone. So again, your body snapping into rest and digest mode, getting into a different place. There's also some research to show that maybe it is also helping to enhance the gut microbiome. Again, that's like much bigger of a topic that we can try to tackle in a different Instagram Live, but maybe there's some feedback to that. Probably I would suspect that it's still about downregulating cortisol levels and the nervous system, and trying to help us to feel like we're safe and we can recover from these things, and therefore good bacteria in the gut microbiome can be better at, can grow and can be fostered there. But unfortunately, in most research studies, though like sometimes we'll see some benefits to the vagal nerve stimulators in irritable bowel syndrome, it's not been reproduced. And in medical research, reproducing a finding, right? So you get a test result in one way. If you can reproduce that test result, we can rely more on that. And that hasn't really been borne out to show that in vagus nerve stimulators. So I don't dislike them. I think they can be very helpful for increasing a distraction to your brain, or different stimulation to your brain. But I think that it's tough to feel like they're going to be the end all be all, unfortunately. You can harness your vagus nerve in other ways though. And so, strategies for that definitely include psychotherapy, right? Talking to people, talking to a therapist who you feel comfortable with, and talking about the stressors. It releases some of the burden that you're carrying around. Being in groups with other people that are struggling with functional disorders, whether that's gut-brain axis disorders or something else, it can definitely make you feel less alone. And then, like I'm saying, medications definitely can play a role in that as a tool to help your nervous system feel like it can be a little bit more tamped down. So, it can be very helpful to do both medications and psychotherapy if you feel like you can, no pun intended, stomach that and go forward, because there's definitely healing to be done in gastrointestinal psychiatry. And even if you don't have a specific gastrointestinal psychiatrist, you can absolutely feel better from your functional or gut-brain axis or residual symptoms of inflammatory bowel disease or the anxiety or mood symptoms that go around that. So hopefully that's helpful and sheds a little bit more light on that. I'm just going to look here for a second to see if there's anything else that question-wise that I might be able to help explain. And of course, if I didn't get to your question or if there's something else that would be really helpful for me to chat about, I would love to hear from you guys. Definitely send me comments, send me DMs so that I can try to answer questions and continue this conversation. I'm going to keep it at 8 o'clock so that everybody can get off to the rest of their evening and dinner and all of that. And thanks so much for joining. I've really appreciated seeing, really great turnout and a lot of people that have joined throughout the half hour. So thanks so much for being here, and I will see you next time.